What is rehab or rehabilitation? My name is Fred Bagares, a board-certified sports and spine medicine physician in Virginia Beach, Virginia. After 10 years of practice, I still find musculoskeletal medicine both fascinating and challenging. This podcast is about the lingering thoughts and questions I've had after residency and fellowship. My hope is to spark discussion, challenge dogma, and share my experiences in musculoskeletal medicine. Welcome to the Talking Rehab Podcast. Let's talk about the value of a diagnosis. How important is a diagnosis? And ultimately, it comes down to who's asking the question, the patient or the clinician. I would argue that a diagnosis is probably the most important or valuable to the patient when compared to the clinician. And I'm going to talk about essentially why that is and at least some of my observations over the years. So a diagnosis is essentially a label. It gives some context to the actual condition. Now, as a musculoskeletal specialist, the common diagnoses or symptoms that I see are associated with shoulder pain, hip pain, spine pain. And for a patient that doesn't have any medical background, what do they have? They have Google, right? We all do it. From my standpoint, it at least gives people a framework of how to understand what the problem is. You know, all the patients can tell is that they hurt and they're trying to figure out how did it happen? Are there any precipitating events that led to it? Whether or not there are any risk factors that made them prone to this type of injury or this type of pain. And more important, how can they stop it from coming back? The issue of recurrence of symptoms. I think that's really the framework that both patients and clinicians view it, but just feel like it is obviously a lot more important to patients. It's also the source of where I think some of the frustration or the differences in the value of a diagnosis that I see between patients and clinicians. You know, peace of mind gives people a certain amount of certainty. What is the problem and what it's not? Is the shoulder pain related to a rotator cuff tear or just a tendonitis or bursitis? A physician's standpoint, physicians will almost always look for the conditions that will kill you, or that are fatal for obvious reasons. Someone comes into the emergency room with left shoulder pain, almost automatically they are not thinking, is this a rotator cuff issue? But they want to make sure that this is not a cardiac issue. Left shoulder pain, shortness of breath, tingling down the arm, those are pretty classic signs for coronary artery disease or signs of an acute heart attack. So in the emergency room, you're going to be getting an EKG, getting lab work, getting a chest x-ray, maybe a shoulder x-ray. And at the end of that visit, no matter how painful the issue is, emergency room physician will say there's no coronary event, there's no signs of a heart attack, and you're safe to go home. Now, from the physician's standpoint, that obviously gives them peace of mind that the shoulder pain that they see in front of them is not fatal. But from the patient's standpoint, that's great, but they still don't exactly know what's going on. And the emergency room is not the place to rule out non-fatal causes of shoulder pain. And so they typically get discharged to go home, and they're told to follow up with their primary care physician. And I think that this is a major source of frustration for patients. Physicians, again, it goes back to that certainty of that this is a non-fatal condition, great for them, but not always great for the patients. But at the same time, it's hard to rule out rotator cuff injuries, rotator cuff tears definitively in the emergency room, which is really a place for emergencies. A diagnosis, I believe, provides patients also a point in time where they are in terms of the actual problem. You have a shoulder issue, pain for a day or two versus a year or two. I think If you don't have a diagnosis at the 1 to 2 year mark, you are suffering. You are lost. You have no idea exactly where you are. Once people find that actual diagnosis, it will automatically start to go and look up their condition. They'll start meeting with different specialists to get their experience with this condition, to help understand where they are in the actual journey of things. Are they at the beginning? Are they at the middle? Or are they at the end? Is this a lifelong issue? And that it can be very frustrating for patients because, again, getting a very specific diagnosis is not always a very straightforward issue, particularly when it comes to musculoskeletal issues. Other things to consider of what a diagnosis provides a patient is, I think once you have a diagnosis, it gives you some reassurance. It also gives you a sense of community. My patients that I've seen over the years that have had a chronic condition and they're finally diagnosed, they have this massive sigh of relief because they finally know what's going on, and they can go start looking things up on their own, and then they start to see that other people have the same condition. There's several support groups online and in person. So in a way, I think it really gives people a sense of belonging and community, which I think is very helpful and key to managing chronic conditions, and also, preventing that feeling of being alone. Last thing I'll mention is sometimes the diagnosis is tied to compensation, whether or not it's a work-related injury or a disability or a personal injury issue. Diagnosis is sometimes very, very important. Unfortunately, the way some of these compensation models are set up, they're not really aligned with trying to figure out what actually is the cause of or the actual condition. It's usually trying to assign causation. And again, I've had patients over the years, lawyers, trying to tease this apart, and it can be very tricky. Certain diagnoses, more weight in a medical legal setting. That's all I can say is it can be kind of complicated. I'm going to flip to the clinician side of things. The same thing, diagnosis does provide a framework for clinicians. It can help understand a mechanism of action, start to discuss treatment options, establish referral patterns for imaging, for therapies. And so again, it is a starting point. And I will kind of emphasize starting point because a lot of musculoskeletal conditions are not diagnosed easily with a simple test. So X-rays is probably the most common, or probably the first study that will be obtained. And X-rays are great for certain things. They're great for fractures, looking for alignment issues, but they don't really image any soft tissues. So it gives you no information on tendons. It gives no information on cartilage or bursitis issues. So we kind of rely a lot on our clinical skills. And so if you're kind of a first-line person, a physical therapist, primary care physician, you do your physical examination, you come up with a differential diagnosis, and you start to give a label. And it was always a very confusing thing for me, especially as a medical student, because again, as a medical student, very much like a patient, I was still learning. I have some medical background, but I don't have experience. And I would see clinicians just use diagnoses that didn't always seem to make sense to me. Again, I'll use this shoulder analogy or example. Someone comes in with shoulder pain, and I would see it be labeled as a shoulder pain issue, a rotator cuff partial tear, or it would be labeled as a bursitis issue, or it would be called a sprain/strain. And as a student, I was like, well, which one is it? So I was really counting on my attending's experience. They did an exam, they did a Hawkins and Neers test and the strength testing, so on and so forth. And they just know that it's not a tear, or they know that it is a tear. But, after practicing 10 years now, I realized that it's really just a starting diagnosis/label. It's just a starting point for a lot of patients. However, this is also another area another area where patients can get confused and frustrated because it's not clear based off of what they're reading. They will get the notes, see a diagnosis code that says partial tear, sprain/strain, and because they have limited knowledge, or the opposite, they have Dr. Google, they have all sorts of information. And as we all know, Dr. Google is both our friend and our foe. I'm kind of curious how newer physicians are starting to kind of come up upon this whole diagnosis issue. So as I evolved, I started actually being more broad in my diagnosis before actually giving it a definitive diagnosis, because I didn't like the idea of calling something or writing down a diagnosis of a sprain or strain versus a tear when I couldn't be sure based off of my physical examination. So I would lean on shoulder pain or impingement syndrome if I only had an x-ray. Now, because I have ultrasound, when it comes to soft tissue issues, I can be a lot more definitive about my diagnoses. I can see bursitis issues. I can see tendinopathies and tears of tendons or ligaments, things like that. So I can be a lot more definitive. But as I learned, I think you have to be very, very careful as a physician, about how you start off your diagnosis, because the medical records they kind of go everywhere. They become accessible to patients, and they don't always have the context. So I think that's, again, one particular area, establishing a diagnosis versus finding a more correct one. As I started to move along in the whole rehabilitation process, I would start off with an impingement syndrome. I would refer them off to physical therapy. And if it helped, great. If it did not help, then I would move on to more advanced imaging like an MRI. Now, again, switching back from a patient standpoint, it's the most obvious and the most correct question is, does it make more sense to kind of know what you're dealing with versus just guessing? And I think that's 100% a fair point, and it really challenges to come up with a good answer for that. Because I think overall that's very obvious, like how can you treat something when you don't know exactly what it is? And what physicians tend to do is that, well, we know it's not something deadly, not convinced that there's something torn or damaged. Therefore, these are the treatment options that are available to you, often a non-surgical treatment, injections, medications, referrals for physical therapy evaluation. Knowing that there is a shoulder impingement syndrome versus a partial tear from a physician standpoint is kind of a distinction without difference, because physicians know that partial tears are largely managed conservatively, but patients don't know that. And I think, again, that's why they ask that obvious question: why don't you image before we start? And I think as physicians, we kind of, just rest on the fact that, well, the imaging, even if we decided to image now, it wouldn't really change your treatment options, which is true. But I think that there is kind of an elephant in the room situation, because insurance is a major factor. We know that ordering an MRI off of the first visit for someone that has purely pain symptoms without any focal muscular or neurological deficits, more likely MRI is going to be denied, and will add more paperwork for us to appeal. And then ultimately it's kind of their rules situation, and we end up having to do conservative management anyways. So again, here's a point of contention is I think that some physicians, and myself included, we just, rather than have to deal with the frustration of extra paperwork, rather just kind of play by the rules. Fortunately, the rules kind of dictate the way the game is played. And I think as a physician, especially a new physician, it really does change how you think about things. And it's really unfortunate, because I think that that insurance kind of dictates what you can know about the condition, meaning when and where. really limits your differential diagnosis. It limits, think of disease processes, meaning that if we know that shoulder injuries are managed conservatively, we don't typically order imaging in the very beginning, and we just kind of assume that most shoulder issues will go away with time or physical therapy or over-the-counter medications. But I mean, that's great, but that's not exactly a great way to understand the natural history of shoulder problems. Emphasizing the word problems, because if we see someone day one, we're just guessing on what it is. I think that there is value in knowing sooner than later, because let's say that I have someone with a shoulder problem again. I refer them to a physical therapist, and just knowing that an X-ray didn't show anything unusual, no arthritis, no, it was a non-traumatic situation, so fracture, all that stuff is very unlikely. So that's one situation. Now, what if you had an ultrasound machine and this person had the same range of motion, still has pain, and you realize that they have a full thickness tear? As a physician, does that change your decision making? Does that change when to follow up? Does that change acute management? I think it's an interesting question, and I just don't think that if you're in an insurance-based model that you really run across that scenario. Someone with full range of motion shoulder pain and no imaging, they will typically receive conservative management. But what if you know that they have an acute tear right off the bat, but they still have full range of motion? Does that change how you manage them? Similarly, I think it can also have kind of negative effects, meaning that if even with a full thickness tear with great range of motion, the management would still likely be starting off with physical therapy and just letting and seeing how much recovery that you actually get. For patients, if you now you have the burden of knowing, the burden of knowledge. Now you know that despite full range of motion, you have a tear. And even just a partial tear versus a full thickness tear, I think, are essentially the same for patients. All they hear is tear. And for some people, it gives them context, it gives them relief, and they trust the program that's laid out by their clinician. But for some people, even if it's a very small tear, they're frozen. They have a very emotional reaction to what they now know about their shoulder. They could have full range of motion, but if there might be a partial tear, maybe in their mind, I think that they think something might be hanging on by a thread. So it sometimes can have a negative effect. And that goes back to physicians being aware of information, how our patients are understanding it, and trying to read them and get it so that we can give them some reassurance regarding the overall condition. As we wrap up, I wanted to leave with a final, kind of some final thoughts for you young clinicians out there. I challenge you guys to truly think about what is the value of diagnosis. And it's going to be hard, but try and subtract out the financial implications of the diagnosis, because let's be honest, it does make a difference. The unfortunate game is that the certain diagnoses get paid and some don't. Very important for people that are just starting to get into medicine to really question, what is the purpose of this diagnosis? What does it mean to you? What does it mean to your patient? Because ultimately, once the patient and the physician's views align, that's where people actually start to feel reassured and compliance goes up, and generally people start to feel cared for. So it's really very important, I think, as physicians to truly understand what a diagnosis means to you. It's not just a label. It should mean more than that. And I hope that you guys value education and also your patient's points of view. Ultimately, if you can get these two to sync up, your outcomes are going to be excellent. Thanks again for listening. Thank you for listening to the Talking Rehab Podcast. I hope that this podcast stimulates you to question your own practice and how you approach rehabilitation. I truly appreciate your time and attention. If you enjoyed listening, make sure to like and subscribe to the podcast. I wish you a movement-filled day. Take care.